Welcome, everyone. My name is David Hamer. I'm a professor of global health and medicine at the Boston University Schools of Public Health and Medicine, and have a long-term interest in migrant health and in particular Chagas disease. Today, we're holding this immigrant health symposium in honor of World Chagas Day. And I think, Sarah, do you want to introduce yourself quickly, my co-moderator?
Sure. My name is Sarah Kimball, and I'm a primary care doctor at Boston Medical Center and the co-director of the Immigrant and Refugee Health Center at BMC, which is a clinical care site meant to address the barriers that migrants face in getting their healthcare needs met. So we're delighted to have you all here today and to be hearing from some really fantastic speakers.
Great. And Maya, could you put up the next slide? So this is a CME approved activity, and just a couple of quick comments. I mean, at the end, there's going to be a link available for those who would like to get CME or similar nursing contact hours. There's no commercial support for this, and none of us have any vested interests or conflicts of interest. Why don't we move ahead? I'm going to introduce the first speaker. So it's my great pleasure to introduce Sandro Galea. So Sandro is a physician, epidemiologist, and author. He's the dean of the Boston University School of Public Health and a Robert A. Knox professor. He has a medical degree from the University of Toronto and then graduate degrees from Harvard University and Columbia University, as well as an honorary doctorate from the University of Glasgow. He has held various academic and leadership positions at Columbia University, University of Michigan, and the New York Academy of Medicine. And he has published a serious amount of really high quality articles in the peer-reviewed literature and has been a regular contributor to a range of public media about the social causes of health, mental health, and the consequences of trauma. He's past chair of the board of the Association of Schools and Programs of Public Health and past president of the Society for Epidemiology Research and Interdisciplinary Association for Population Health Science. And he's an elected member of the National Academy of Medicine. And he has been an absolutely amazing gift to the BU School of Public Health as dean over the last several years. So Sandro, we'll look forward to your presentation. Thank you.
Thank you, David. Thank you. That's very kind. Thank you all for having me, and thank you, Sarah, for pulling this together. A lot of my attention on issues of migration and health at BU really were focused with initial conversation with Dr. Kimball, which I'm very grateful to her for helping sharpen my thinking on that. Let me share my slides. And David and Sarah asked me to do an overview presentation, really a brief overview presentation about migration and health very generally. Just by way of acknowledgement right up front, this is based on work that it's a book that's emerging with two colleagues, with Catherine Etman, School of Public Health, and Mohammed Zaman in School of Engineering. It's going to be a book on migration and health that will be coming from University of Chicago Press probably next year. So really, I just wanted to give a very much an overview of migration and health as I see it, by way of setting the stage for the rest of the symposium. So let me start with why even talking about migration, and because I always feel like when we do something like this, right, we are you do a symposium on migration and health, and you attract people who are interested in migration and health, which is fair enough. That's how it works in the academic world. But I think it's worth taking a step back and saying, how does this fit in? And I think migration fits in because as we look forward, it is one of four changes, processes that are really shaping our health, the health of the planet over the next 50 years. And those four forces are as follows. I think one of them is urbanization. And of course, these forces don't exist in isolation. They influence each other, they intersect with each other. And one often has consequences for the other. But urbanization is one of the key ones. I mean, urbanization has been an enormous demographic force that in 1800, only 5% of the world's population is urban. By 2010, more than half the world's population is urban. By 2050, we're going to have 2/3 of the world's population is urban. So there's been an enormous move of people towards large, densely concentrated settlements. And again, that clearly intersects with some of the things that we're talking about here. So I think urbanization is one of the four. The other one is population aging. We are, as a world, clearly moving away from the traditional population pyramid to that we presumably we all or most of us here on this call learned way back in high school or early university classes to population barrels, where the traditional pyramid with more young people and then winnowing down to more older people really is changing to actually having more and more young people, but also more and more people who are older. And that is going to change the world dramatically. I mean, one of the data points that I feel like we are often not aware of is that there are in the world now more people over age 65 than there are under age of 5, which means that if one were to say over the age of 65, you're now entering the older adult group. Well, there are more older adults than there are young children in the world today. That is a dramatic shift in the world. So that I think shapes how we think about the world, shapes how we think about population health. And again, it intersects also with our typical notion of what is a migrant, and migrants being young people versus migrants being older people, et cetera. The third shift is climate change. It's the global population change and climate. This is a picture of the gateway to India, and covered up in smog due to climate. And climate, of course, intersects with urbanization, intersects with industrialization, also intersects with migration, because in the intersection with migration, there's phenomenon which many of you know about, which is climate migrants. And it is both influences and is influenced then by population migration. And the fourth is population migration, which I'm going to talk about here. But I thought it was helpful to start by saying, how do we think about population migration as a large overarching force that is actually shaping our world and that intersect with these other forces? And I think these four forces are going to be really like a braid of influences on the world's health over the coming 50 years. So now let's talk a little bit about migration. So let me now sort of do some grounding about migration. I think it's helpful, and as us to speak about, sort of to talk a little bit about scope and what we actually mean by migration and who's a migrant, et cetera. So this is from the World Migration Report. I think it's a bit of a handy diagram that when we're talking about migrants, we're talking about people who actually are moving. We're talking about migrants, we're talking about people who are moving across borders and within borders. And for the purpose of this, I'm talking principally about cross-border migrants, and refugees are a subset of migrants. And that's how to think about it. So when we're talking about migration and health, there's obviously a strand of intellectual thought and practical work around refugees specifically, but refugees ultimately are a part of a subset of migrants. Now, what's the scope of migrants? There are about 272, most estimates are focused on that today, but 272 international migrants, which means people have crossed borders, which is about 3% of the world's population. Now, that's one way of thinking of it and saying, well, that's not very many people. But if international migrants were one country, just to put it in perspective, they would be the 5th largest country in the world after China, India, United States, and Indonesia. So 272 million people is essentially the 5th largest country in the world, which gives a sense, I think, of why thinking about migrants and thinking about migrants and the particular forces that influence migrant health and how migration is associated with other forces becomes really important. Just a couple of notes on this, that this is really reinforces what I said before. There are 272 million migrants, about 1 in every 30 people are migrants in the world. And there's tremendous variability in migrants across the world. That some countries migration is normative, in other countries migration is actually quite unusual. And in fact, this has changed over time. So I want to just show you a little bit of a video, or at least a slide video of migration across the world. And this is, so I'm really going to fast forward through decades. The way to read this is the white countries, the countries that are white, they have no net migration. And the yellow countries are immigration, so countries where people are going into, and the blue countries are emigration, countries where people are leaving. So you start in 1960, so just starting about 60 years ago. you see that people were leaving sub-Saharan African countries and sort of the Russia, Asia, the Eurasian part of the world. That's 1960. 1970, you see that starting to shift a little bit. Now 1980, now you're no longer seeing migration actually from net migration from China and Asia, and you're seeing more emigration now from South America, which you weren't seeing before. 1980, now you have sort of, again, now you have South Asia, Sub-Saharan Africa, and also Latin America. That's solidifying in 2000. That's roughly staying the same. And now you're seeing Eastern Europe becomes a source of emigration in 2020. And now projections moving forward, 2030, 2040, and that's where the projections end. So fundamentally, emigration is from all over Africa and from all over South Asia. Those are the two areas which are projected over the next 20 years to be a greater source of migrants, of countries from where migrants come. So just to orient this, let's talk about the present. This is 2019. On the left is the destination countries by, and this is absolute amounts, dealing by per population, but I think it's helpful to think about absolute amount, which is where are the top destination countries, and the right is where are the countries from where migrants mostly come. So what you have is the countries where there are most migrants living are this country, the US, Germany, Saudi Arabia, Russian Federation, and the UK, and then UAE. There are obviously dramatic differences in why people are migrating to US, Germany, and the UK versus Saudi Arabia and the UAE, and as well as the status of those migrants. There's pathways to residency and citizenship in some countries, but not in others. Countries like UAE. UAE is a really interesting example, although it's actually quite small. I mean, not small, it's sixth in terms of number of destination countries. Per population is actually the highest because 90% of the population is migrants in the UAE. Of course, there's all migrant labor and not people with a pathway to citizenship. In terms of what migrants come from, you have India, China, Mexico. Mexico is almost all to the US. Syria, which I'll talk about in a second, and Russian Federation. I just want to point out that Russian Federation is actually both one of the largest receiving countries as well as the one largest exporting countries. It's the only one that's actually in both places. And then when you look carefully, you'll see what I talked about before. You have Bangladesh and Pakistan. So now you're dealing with Asian countries and also Eastern European countries, places like Ukraine, as countries of destination origin countries. So it just gives you a sense of the global picture of where migrants are coming from and where migrants are going to. Now, just to shift a little bit to refugees, which are a subset, as I said a second ago, it's a subset of migrants, but it's in particular a subset of migrants that have to migrate because of instability and danger to self and threat to their existence. And I just want to show, this is the top 5 countries that are origins for refugees. And I just want to point out, before getting into Syria for a second, you have Afghanistan, Myanmar, and Somalia, which have been consistently countries where, because of tremendous political instability, where there has been, they've been source countries for refugees. But look at the dramatic increase in Syria and Syrian Republic and South Sudan, which really were not sources of migrants, Syria in particular. And then they became so as the country became unstable. And one sees this when you go through history, that there are countries that sort of where you have a collapse of the economic and social order, and they become refugee-emitting countries. And of course, the reason I'm saying this is because to really illustrate the complexity of the migration process and how migration ultimately shapes our world. And this looks at the host countries of refugees. Although I showed you the host countries of migrants, the host countries of refugees are actually quite different. The country with the most refugees is Turkey, which is directly linked to Syrian refugees. You've had consistently Pakistan has received a lot of Asian refugees, Uganda, which has received a lot of other African refugees, and Sudan, which has received a lot of refugees from South Sudan, and then you have Germany. So that's the global picture, really, of migration, where migrants come from. And now let me shift, and I want to be conscious of my time because I don't want to nip into anybody else's time, about how to understand migration and its influence on health. So when we think about migration and health, I think it's really helpful to nest migration within the rubric of population health, because fundamentally migration is, as I said, one of these four forces that influences health of populations. And this is a definition of population health sciences from a book which I've done, so I don't have a citation here, but it's a study of conditions that shape health within and across populations and of the mechanisms through which these conditions become health. So when we're thinking about population health, we need to think about the health of particular populations and what shapes that health. And I think it's handy to think about that by thinking about the forces that shape our health. I think it's true for the forces that shape our health, and it's true for the forces that shape the health of migrants. So this is, if I said, a figure from the upcoming book that I mentioned. And I think it's helpful to think of migrant health by thinking about the characteristics of place of birth and place of residence, which is where migrants come from and where migrants are moving to. And within that, one can think of a classic social ecological approach or a classic multi-level approach, however you want to call it, that the health of the individual is influenced by their social relationships, by their living conditions, by their neighborhoods, by their institutions, and by social and economic policies. That fundamentally, it is that set of conditions in the country of origin and the country of destination that shapes the health of the migrant. And that concept, which is really is a fundamental social ecological concept about the health of populations, applies equally well to migrants as it does to applying to the health of anybody, with the added wrinkle that now you have country of origin and country of destination, both of which matter. Which means then forces like isolation, again, country of origin, country of destination, quality of nutrition, quality of housing, quality of living, occupation, transportation, that all of these forces matter. So thinking about a social ecological framework on health, which applies itself to migration and the health of migrants, I think is actually very helpful. The other framework that I think is helpful is to think of the health of the migrant across the migrant's life course. That fundamentally our health is, for all of us, is a product of our life experience. And this is I think a simple framework that shows that. So the way to read this is on the y-axis, you have development of poor health, and the x-axis you have age. And you see genes that are sort of genetic factors are roughly the same throughout our lifetime, but then we accumulate risks through prenatal period and infancy, adolescence, adult life, older age. And then you see this line here, which means we're accumulating risk. So, right, prenatal risk, our mother, when mothers are safe, mothers access to care. Then in infancy, exposure to violence, access to food and education, adolescence, social support, discrimination, family dynamics, whether you smoke or drink in adult life, social isolation, access to care in old age. And I think when we think about migration and health, we can actually think about how is it that any of these processes intersect with the migrant's health in the origin country and the destination country. And of course, there's then always also the way of thinking about the migration process as a dynamic process. And these same influences over the life course that I talked about are affect the migrant through the pre-migration phase in the destination country, the movement itself, the characteristics of the movement, which typically intersects dramatically with the life course, and then the arrival and integration phase, and sometimes there's return, and you have cyclical migration. So I think it's helpful to think of a migration health within a frame, a social ecological frame across the life course and across the cycle of the migration process, thinking about pre-migration, peri-migration, and post-migration. So let me just now quickly come to migration and health inequities as I start to wrap up. So within that, I could talk quite a bit about particular examples about how migration affects health, but I'm really not going to do that. I'm just going to show you, this is a couple of tables. This is from the World Migration Report of 2020, where you can talk about multiple different health concerns about migrants, child migrants, migrants in detention, which are access to healthcare services, where people are living, social isolation. But ultimately, this is a big table, and I can show you the second part of the big table about talking about particular concerns about adult migrants or LGBT migrants or survivors of human trafficking and refugees. But the reason I want to show you this table is not to even get into it, because when I was approached to sort of say frame this, I was trying to think of how do I tell you this in 20 minutes. And anybody can read this table, but fundamentally, I think it's actually helpful to just think about the framework, think about the life course framework, think about the social ecological framework, and that is how it intersects with the particular health needs of particular migrants. I want to show you just a couple of slides from a recent survey that I thought was just indicative, just because we're all talking about COVID-19 all the time, as everybody knows. In terms of COVID-19, one survey that was actually done by WHO about why are migrants not seeking medical care when they have suspected COVID symptoms. And the two biggest reasons are, well, the three biggest reasons are lack of financial means, fear of deportation, lack of availability of healthcare. And I actually thought there was obviously we're dealing with about why aren't you getting treatment for COVID, which is a very particular thing, right? A particular moment in time. But I thought it was indicative of, which is why I'm showing it to you, of the broader migrant experience, right? It's that fundamentally you're dealing with socioeconomic means. I mean, it's overwhelmingly, right? This lack of financial means. That's what's driving, and that's what's driving the migrant experience. Then you have fear of deportation. Then you have lack of availability to healthcare, which everybody here understands. It intersects very much with the migrant experience. So I just thought this one slide asking this one specific question really captures the migrant experience, that the majority of the time you're dealing with socioeconomic conditions linked then with fear of deportation around the process of migration. And then also in the same survey, they looked at the proportion of migrants who are not able to follow public health social measures. And the different colors are different WHO regions, which broadly behave the same way. But they looked at things like hand washing, physical distancing, avoiding public transport, avoiding leaving the house. And what I want to show you is that, you know, most people can wash their hands and most people can physically distance and cover their mouth and nose. But now you're getting to migrants, well, it's really hard to avoid public transportation, avoid leaving your house, particularly, remember, when your primary determinant about what you're doing is, really requires you to actually make a living, given that socioeconomic pressures are the key pressure on the lives of migrants, which then becomes health. I'm just going to skip that slide because I just want to end on these two slides because I want to stay to my time. So I just want to quickly talk about, I think there's a tremendous opportunity for scholarship on migration and health. This is from a paper that I did with Dr. Salma Dalla recently, where we actually looked at all the papers sort of in global health broadly, and I would argue migration and health, just like issues of urbanization, climate change, and aging, really affect health globally in multiple journals. And the reason we did that is we actually wanted to map out what are we publishing about in journals. And what we're publishing about in journals is things, these are clusters of publication, are things like governance, maternal child health, infectious disease, surveillance, sexual reproductive health. We're publishing nothing really about fundamentally the processes of migration proportionally, or about anything things I'm talking about the life course exposures to forces across a social ecological framework and through the migration process. And I think all of that fundamentally is what creates the conditions that creates health of migrants over their lifetime. Thank you for having me. I will stop there.
Great, thank you, Sandra. That was an excellent overview and very informative, and thanks for keeping the time too. Much appreciated. I'm going to let Sarah introduce the next speaker.
Excellent. And we'd like to just encourage you to put questions into the chat or send them to us. We'll be doing mostly questions at the end with the panel, but please, as they occur to you, put them in here and we'll be aggregating them for the panel at the end. So I am absolutely delighted to introduce Dr. Paul Geltman. I will say that in addition to the many wonderful things that I'll tell you about that he has accomplished in his career, he's been a personal mentor for me in my own career. And so it's a delight to be able to have him here speaking with us today. He's truly a national expert in public health and particularly on the topics of immigrant and refugee health, and has spent his career working throughout the Boston, Dorchester, Cambridge, Roxbury neighborhoods, really working and focusing on issues of most import to low-income residents, particularly immigrants and refugees. He's currently at Upham's Corner Health Center, where he's the chief medical officer. And so he's had really an illustrious career thinking about pediatric quality improvement initiatives. And we won't go through all of them because I want you to have time to learn from him. But I will say that he is an associate professor of pediatrics at BU School of Medicine and Health Policy and Health Services Research at BU at the Dental School. And he's been the medical director for refugee and immigrant health at the Massachusetts Department of Health for many years, which is the context in which we first encountered each other as one of the refugee resettlement sites at the Immigrant and Refugee Health Center. So I have had the opportunity over my career to learn a tremendous amount from Dr. Geltman about health screening for immigrants and refugees, and I'm just delighted to have him share this knowledge with you today. Thank you so much.
Thanks, Sarah. Let me get my slides up for you. 1 second here. Okay, you should be able to see that now. I'm going to switch to the slideshow view. All right. So I really have to start by, of course, thanking the organizers of this session today and for inviting me, Sarah in particular, with whom I have a long relationship. And I want to just comment that Sandro's presentation leading up to this really was the type of things that I like to talk about. And when I was asked to talk about health screening, I had to take a deep breath and pause a little bit, because it's not so easy when you're talking about migrants as a global population, or even at a national level in the United States, to think about it as a single unique population, when in fact it is a multitude of heterogeneous populations, and there is no real single approach. So it's more about general principles that should be applied. So while I originally was thinking I would love to do the type of slides you just saw with graphics and less text, it really required me to have a little bit of a drier presentation. So with that introduction, let me get into it here. And so as I mentioned, I wanted to focus more on general principles. Think of Sandro's presentation and the themes really as sort of the ingredients of the recipe. And I'm going to now sort of give you some of the instructions on how to assemble those ingredients, and what needs to be applied in the exam room when you are with a new immigrant. But again, it's not, I'm actually going to use the word cookbook later on, but it's not a how-to list of exactly what you need to apply each time. It's just more of a constellation of the general principles and content, as the heading of this slide says. So first, as you just heard, you really have to look at what the migrants' overseas history is, the origins, where they come from. The older term that I know Dr. Hamer's familiar with, that you don't hear mentioned as much, is geographic medicine. It's really about where the person or family is from, in terms of what are their health risks and issues that may need to be addressed during your medical encounter with them. And then overarching all of this are the cultural considerations. And then you have to think about what kind of a history and exam should you do, because really it may need to be fairly targeted at a first visit with a new migrant. You may not be able to do a more comprehensive history and exam for a variety of reasons. Then the next step, of course, is what kind of screenings should you do? And depending on what your role is in the healthcare system, your approach to screenings might be very different. So for example, when we're looking at refugee health assessment or refugee health screening of people who are coming through a government-supported resettlement program, typically there's a fairly targeted, protocolized screening that needs to be done. Whereas if you're just seeing someone who migrated to the US on their own accord, you may want to do something more specific to their background and maybe more targeted to their personal experiences. But you have a little more flexibility in what you can do as a result. So some of the four general areas that I focus on are growth and nutrition. As a pediatrician, to me, this is huge. And over the course of my career, I've seen the evolution of the focus on growth and nutrition from undernutrition and underweight and stunting to more of a focus when the refugees arrive in the US on obesity and malnutrition, but overnutrition in some sense, almost like you'll see among populations in Western countries and here in the US. There's going to be laboratory screenings, particularly focused on infectious disease, but not exclusively. Social screenings are important, and sort of a subcategory of that would be behavioral health screening. Again, as Sandro mentioned, the impact and role of trauma is ubiquitous in many migrant populations. Obviously, less so perhaps on someone who's coming from, I don't know, a country like France, say. They may not, coming to the US for a doctorate or a postdoc fellowship or for employment, they may not need quite the emphasis or approach that you might take with other migrants, but still there are considerations even there, that they may have requirements for their educational or work placement that you'll need to consider. So vaccinations, of course, are very important as well. And then education and orientation to the healthcare system and emergency services and social supports in the US. So starting with the overseas history and origins, as I mentioned, a focus on geographic medicine, really you have to ask the question, from where did your patients come and where have they been? And then the corollary to that is, what are the health risks associated with those locations? And I can't give you the answers to those questions. This is where you have to do a little homework and a little research. Similarly, then exploring trauma, both physical and psychological. What have they experienced? And that goes along with where are they coming from and where have they been along the route that ended up with them in your office. So as I alluded to just a moment ago, you also have to think about who they are. What's their visa? That has implications for what you should be doing, what their health risks may be, whether they've already had some form of health screening or vaccinations overseas. So for example, recipients of permanent visas have overseas health screenings, refugees, derivative asylees, etc. And that may even include vaccination nowadays, as well as presumptive treatments. Among refugees, you'll see this routinely now for malaria in sub-Saharan Africa, schistosomiasis, strongyloidiasis, intestinal helminths. Don't just assume, though, that a migrant with certain visa types, like employment visa, that they may not have some undetected health issue or risk factors. You still want to try to stick with your principles and think about what might be applicable to that person. And then again, cultural considerations, it's a huge, huge topic. So you can't try to be the expert on this. That being said, if you are working exclusively with patients who typically are from one predominant ethnic group or national origin, yeah, take the time to learn some of the basic concepts and principles of their cultural construct. What are their expectations for you as their doctor? How are they going to approach their own health and healthcare? But if you're working in a multicultural environment, like many of us do, you really have to go to your toolkit of what are the general principles, the global principles. So engaging in a dialogue, respecting the patient's perspective, which almost certainly will be different from your own, defining expectations for both the patients and yourself, and discussing new concepts in a two-way fashion on our end. My end, it's going to be about what is primary care, what about oral health. Can you imagine most migrants hearing the term a dental home, right, or a patient-centered medical home? They're not going to know what that means. So you can begin the introduction to some of these concepts, and it's an ongoing dialogue that you have to have with patients as you establish a relationship. And so having that dialogue means you have to address linguistic barriers as well. And really, you should use professional interpreters whenever possible if there is a language barrier. Even bilingual staff may not be as good as a professional interpreter. And just remember, people like me or you, we may be trained in how to use interpreters, but your patients aren't. So you may want to try to guide them, or just understand that you're going to ask the question directly to them, looking at the patient, and then the patient's going to turn away from you and talk to the interpreter if it's someone in the room with you. And you can't change that dynamic, so you just have to go with it to some extent. And then lastly, when you're talking with the patient, be very careful about sensitive topics, especially at a first encounter. In our refugee health screening program, we really discourage going down this pathway at a first encounter with a refugee, particularly certain refugees where there might be a gender or sexuality discrepancy, or it might be religious based. So be careful on topics about substance use, gender and sexuality, including female genital mutilation. Be respectful of family dynamics and religious or spiritual practices. And also just be aware that transitional medicines, complementary and alternative medicine practices, these may be something that you're going to have to figure out. For me as a pediatrician, if anybody knows my career, it's been around lead poisoning. And I can give you an example that in my practice in Cambridge many years ago, I was aghast when a Somali family brought in a newborn to see me, and they had that dark eyeliner on that has any number of names. It goes, Tiro, Surma are among some of the names that are used for it, but it's a blemish to ward off evil spirits in many cultures, particularly in Northern Africa, the Middle East, and South Asia. And this family had no transportation. They didn't speak English. Yet they had procured this stuff. And in fact, I found that they traveled 2 towns over they didn't live in Cambridge, but they traveled 2 towns over, and they went to an Indian store in Cambridge, an Indian food store, and it was in the back room behind the counter. You had to know where it was and to ask for it. Yet this family had managed to procure it. So you can just presume it's pretty culturally common in that community. And I actually gave a sample of it to our state environmental toxicology lab to see if it contained lead. And luckily it did not, but it usually is lead mixed with the soot from an oil lamp to darken the color and create a paste. So I was just very lucky that this infant was not lead poisoned. And I explained that to the family, and we talked about it. And we talked about making sure it was lead free and alternatives that could be used. And it was actually a really nice conversation. So it's an example of how it can be a little challenging. And I went to that store, actually. That's how I know all this stuff. I did a little research. So history and physical exam, focus on what's most relevant initially. So I tell people to focus on the migration history, the trauma history, their social history, and their immediate needs, right? What are their priorities? What do they want to get out of the visit? Follow their cues. In pediatrics, we talk about this as teachable moments, where you can't go through your whole cookbook of everything you're supposed to screen for and all the anticipatory guidance you're supposed to do, because there's just not enough time. So follow their cues. Again, be careful about gender dynamics in the exam room. For me as a male physician, when I'm seeing female patients, especially adolescents, or in the refugee health context, if I might be seeing, say, a Muslim female from Somalia, I'll be very careful always to have a chaperone in the room with me. Even if I'm not doing a breast or genital exam, I'm going to be very careful. And yet sometimes it doesn't matter. Thinking back on my career, we were so used to resettling Somalis coming out of the late 90s, the Muslim culture, very conservative in their dress and interpersonal relationships. And yet then sort of the next cohort from Africa were more refugees from both West Africa, Sierra Leone and Liberia, and Southern Sudan. And they had a completely different approach to sort of interpersonal dynamics. And I was almost, stunned when at my very first visit with a teenage female refugee from Liberia, that she wanted me to check her breasts, and she disrobed before I could even give her a gown, and no problems whatsoever with it. And so you do have to follow cues, but try to do what's right. You don't want to end up in an awkward situation that could come back and haunt you later. So vision, hearing, growth parameters, blood pressure goes without saying. More and more among refugee populations, we're seeing sort of that Western culture health profile of chronic diseases, chronic diseases with overweight, high blood pressure, diabetes, things like that. The focus is moving more and more away from infectious diseases in many instances, but not all. And Again, in terms of my experiences and interests, the last thing I'd remind you about in your exam is to do a good oral exam, because we know among refugees coming into Massachusetts, among pediatric patients, oral health problems are the #1 health issue. And that's only passed by latent tuberculosis infection in adults. So oral health problems are going to be a big health issue. So don't forget to do a good exam. Once I had a way back in the day when I was at the International Clinic at Boston Medical Center, I was examining a young Somali girl who lived through the siege of Sarajevo. And I won't get into her whole story, but one of her health issues was that she had bad early childhood caries. But I didn't, if you smile, you often don't see the upper teeth. And I didn't lift the lip, as the dentists say, to get a good look. And the interpreter said to me, oh, the family's asking about this spot above her tooth. And lo and behold, she had an abscess with a fistula forming above her carious upper incisors, which I would have missed because my exam was not thorough enough. So let my mistake be a lesson for you all to always do a good oral exam in a new migrant. All right, so this is my transition slide, and I was so thankful to be asked to do this talk because I haven't been able to use this slide in many years, but this is my tapeworm slide to shift the topic a little bit into infectious diseases and screenings. So I categorize these as hematology, looking at hemoglobin, red cell indices, both for microcytosis, macrocytosis, and anemia. The biggies that we see are iron deficiency, of course, which is highly common, highly prevalent. And in selected populations, we see B12 deficiencies. Among refugees, this was typically identified as a problem among Hindu migrants who were the ethnic Nepali from Bhutan, because they're vegetarians, had a very limited diet, low income, marginalized population, and they had a somewhat high prevalence of macrocytic anemia due to B12 deficiency. You also have to think about thalassemia and thalassemia traits among certain populations, particularly from the Middle East. And looking at the white blood cell level and your 5-cell differential, not an automated diff, but a 5-cell diff, you want to make sure is included, because the key one you're looking for is eosinophils, which sometimes are not included on point-of-care analyzers. So you really want to see that eosinophil level, which is very, very important. And of course, a blood lead level, which should preferably be venous right from the start. The CDC recommends blood lead levels of refugees going up to age 17. That age is under age 17. It's a little arbitrary, but you definitely want to check a lead level on most migrants, not just refugees, on arrival, and then usually within about 3 to 6 months when they have typically are in a permanent housing arrangement because of the risk. A resettlement agency, in the case of a refugee, may have put someone in lead-free housing, but then they may move. And this is a scenario that we've seen over and over in Massachusetts. Chronic diseases I already mentioned. You can think about urine dips, blood glucose, A1C levels, lipid screening, and then blood pressure measurement for hypertension. Cancer screenings, I'm not so sure about that at a first visit with a migrant, but again, it depends who they are. Might be appropriate, so keep it in the back of your mind. Might be something better suited for a follow-up visit or leaving for a little bit down the road. The infectious disease list, of course, is long and does depend on where the person's from. But almost all migrants, with very few exceptions, you want to do a tuberculosis screening. The interferon gamma release assays are the preferred method now. PBDs for the under 2-year-old set. And depending on your institution, the one I'm most familiar with is the quantiferon gold. They're not perfect tests. There are a lot of questions about them still, But the one thing that you avoid with them are all of those false positives for BCG vaccine. And because of that, we've seen a tremendous plummet in the prevalence of what we would consider latent tuberculosis infection, because we're getting rid of a lot of those false positives now in the PPDs. Malaria depends on where the person's from. HIV is something to be considered widely, both one and two. Hepatitis B and C. And this one is evolving. Hepatitis C was something that, you know, people started talking about maybe 20 years ago, but in some early studies, like of refugees, the prevalence was negligible. So it kind of got dropped out of the conversation for a while. Now it's coming back in terms of the targeted risk groups as a targeted test for people who have a risk factor for hepatitis C in particular. Someone recently asked me about D. I'm not sure I would go there yet for screening. And in hepatitis B, which is the biggie, of course, more and more we're seeing the impact of immunization, but it is still quite prevalent. And one word of caution, I'm not the infectious disease doctors, but as we move more towards PCR testing of people who have active hepatitis B infection, the role of the anti-Hep B core antibody, or HBC, which was a popular test for discriminating between naturally acquired immunity versus vaccine-acquired immunity. You have to be careful about interpreting that, because in the most recent clinical guidelines released by the experts on liver disease, I forget the name of the society off the top of my head, they recommended caution in using anti-HBC antibodies because there is now some evidence with PCR that people who actually have the core antibody response coming from moderate to high endemic regions, there is now some evidence that they still may have actually low level infection. So just be very cautious about interpreting that test if you use it. Parasitic infections, the invasive ones, of course, the theme of the day is Chagas disease, you know, thinking about migrants from Central and South America. Then the old standby schistosomiasis, strongyloidiasis, filarial diseases, amoebas. Some of these get to the point, like filarial disease, probably not something most of us in primary care are going to have a clue how to deal with. So if you are starting to be suspicious of something like a filarial disease, it may warrant a referral to an infectious disease consultant. Even to get the test done is very complicated. So straightforward soil-acquired intestinal helminths. Don't forget Giardia, another personal favorite of mine. A lot of the clinical guidelines for refugee and immigrants focus on helminths. The presumptive treatments overseas focus on helminths. Yet Giardia, historically in refugees in Massachusetts, at least, we typically see across all populations at a prevalence about 8 to 12%. Now, many or most of those are asymptomatic, and this is the big unanswered question about which I'd love to do a research project and have tried to do a research project to address is what's the significance of all of those asymptomatic Giardia infections, which if you read the clinical guidelines in the US, you're not supposed to be screening for those, yet they're there. And we don't know what the significance of them is. But we worry with refugees. We know many of them are going to service sector jobs, food handling, and maybe working even in hospitals. And we've just been very nervous to leave those untreated. Derm issues, particularly things like scabies and lice, be careful of watching for. STIs, well, which ones? You know, some are for people who have overseas screening, they're class A conditions. They have to be treated overseas, like syphilis and gonorrhea. Other ones are not designated as immigration-related diseases of concern. Yet again, most of the studies that I've seen of STIs among refugees, at least, the prevalence levels are very, very low. So again, thinking about culture and risk factors, and also, particularly when dealing with adolescents, be very thoughtful about family dynamics. If you're going to test an adolescent for an STI, you really need to make sure that you've got confidentiality procedures in place so you don't cause a huge problem for a sexually active adolescent whose conservative refugee or immigrant parents may not be aware of that history. And then vaccine preventable diseases, VPD titers play a role, particularly for varicella and hepatitis A. I'm not a big fan of them going beyond that, but people will, at their discretion, screen for others like the MMR diseases as well. All right. So more screenings. I'm going to go through this stuff fairly quickly at this point.
Yeah,
Social.
Just as a time reminder, we have just a couple more minutes to transition.
Yeah, I'm almost done. So more screenings, social determinants of health, what supports they have. I've already mentioned this. Educational needs, educational level. Behavioral health screening is very, very important. You can use the questionnaires like the alphabet soup here that I've listed, which we commonly use in primary care. Or there's the RHS-15 for refugees, which is validated for a number of different refugee populations, freely available in multiple languages for those populations. Think about substance use, but be careful, particularly traditional practices like cod, betel nut, etc. Child development is very important, especially for people who may be coming from particularly traumatic or unstable backgrounds, where there may have been a lot of deprivation in the environment of that child. But remember that most of the standard instruments that you can use are probably not cross-culturally validated or validated in certain populations for which you might need to use them. All right, so vaccinations, I'm not going to say too much about this, but just be very wary when reviewing overseas records to interpret them carefully. Make sure you're looking at the right, confirming what the right formulation was, brand names, things like that. Don't confuse measles for measles, mumps, and rubella. And then think about school and migration requirements, what's required, what's not required. And just remember that lack of required vaccinations can be ground for inadmissibility, designated a Class 8 condition. And don't forget to finish the primary series of a vaccine that's been started, especially hepatitis B. Even if they're test positive for surface antibodies, finish the series. All right, education and orientation. These are some of the core topics I like to emphasize. I mentioned primary care. What does health insurance get them? Oral health, I already mentioned. Emphasize fluoridated water, that it's clean and safe to use the tap water in much of the US. Access to care, emergencies, referrals that might be needed, and then follow up as needed. And for things you didn't get to that might be urgent, you can expedite them. Don't forget follow up for vaccination requirements, repeat lead testing. And a good time to check in with most migrants is typically around 6 to 9 months after arrival, when sort of their honeymoon period starts to end and the realities of how difficult life can be in the US start to set in. And think about using frequent sequential visits to help establish your rapport and build relationships. I know as a pediatrician, it's really easy when I have infants and toddlers that I'm seeing every few months. When I have a new patient who's an older kid who might be healthy, a once-a-year visit isn't conducive to establishing a relationship. All right, so lastly, in summary, be cognizant of the regulatory or legal context of their migration, be sensitive to the cultural and linguistic nuances, try to follow a geographic medicine approach, apply general screening principles, have your toolkit, but don't necessarily apply it like a cookie cutter. And remember that not everything is urgent. You don't have to deal with everything all at once. That's it.
Great. Thank you very much, Paul. That was very thorough and a lot of very practical information there. I think we're going to move right ahead into the next speaker. And it's my pleasure to introduce Natasha Hochberg. Natasha is an associate professor. Sounds like somebody needs to mute. I'm getting a feedback. So Natasha is an associate professor in the Department of Medicine in the section of infectious diseases at the BU School of Medicine, and has an appointment in the Department of Epidemiology at the School of Public Health. She serves as the program director for the Infectious Disease Fellowship Program, and now director of sort of tropical medicine within our clinic. And prior to arrival at Boston University, she was an EIS, an Epidemic Intelligence Service Officer at the CDC in the Division of Parasitic Diseases. So her interest and knowledge of parasites goes back many years. She does research on a variety of different topics, including Chagas disease with me and a team that we developed, but also malnutrition and parasitic diseases, well, their interaction, as well as tuberculosis in particular. And I think I'll stop there and let Natasha do her presentation. Thank you.
Great, thank you so much. It's super to be here. I just want to say, I think that the group has really set the stage so nicely, and I appreciated Dean Galea sort of giving us this really overall perspective of the social determinants of health for our migrant populations. And then I think, Paul really helping us drill down into how do we evaluate the factors and how do we evaluate our patients effectively. And so I think that was a fantastic, and we're drilling further down into the middle of this circle, and I'm going to spend just to really briefly talk about parasitic infections, and then focus more of the time on Chagas disease, because this symposium is in honor of World Chagas Day, which is today. So, Paul did give us a sense of there is guidance for the evaluation and treatment of refugee populations when we think about parasitic infections. And so one can take a look at the CDC documentation there and below. And many of these patients, as was said, will have received pre-departure treatment for strongyloides, for soil-transmitted helminths, and for schistosomiasis from endemic countries. But when we're thinking about the immigrant populations, many of these individuals will not have been evaluated before you see them in clinic. And it's important to think about parasite infections because many of these will persist for years and can be associated with significant morbidity and mortality. And so we need to think about those implications. Also, many of them will be asymptomatic, and particularly having had sort of long-standing infections, they won't necessarily have the same symptoms as somebody that's more acutely infected. And so this is a key issue to think about because, for example, in a study that we did in Atlanta among immigrants receiving care at an HIV clinic, almost, more than a quarter, almost a third had, more than a third had a parasite infection. A large proportion were strongyloides as well as schistosomiasis. Another study in Chicago found that also among immigrant populations, there was a large prevalence of parasitic infections. And so obviously the prevalence of infection will depend on who your immigrant patients are, the amount of time they've been here, and some of those social determinants of health that were previously discussed. But this is something that we really do need to think about in our patients. So I said that a lot of times patients will be asymptomatic, but sometimes you'll have a clue in the laboratory results. And Paul did mention this as well in terms of thinking about eosinophilia and whether or not you have a clue based on the complete blood counts. And so I would urge, as Paul did, to not ignore that eosinophilia. That can be a really important clue, especially in your immigrant populations. And so when faced with eosinophilia, and this is not a sort of eosinophil talk in general, but the things I generally focus on are really good review of systems and physical exam, focusing on systemic symptoms of fevers and chills, but also a really good dermatologic exam. So there you can just see an example of cutaneous larva migrans that you might see on your derm exam, good respiratory exam and review of systems, gastrointestinal symptoms. And for example, this is a patient with echinococcal cysts. A genitourinary exam, neuro and ophtho, and there you can see someone with loa and the migrating worm in the conjunctiva. So I think when one sees that eosinophilia, it really bears a thorough review of systems. And then if you're still sort of unsure, and generally I'll start with sort of liver function tests, a urinalysis, and a chest x-ray, just to start to see where this eosinophilia is coming from. And then when one's working it up in terms of the infectious etiologies for eosinophilia, in general, we'll start with the stool microscopy and strongyloides serology. But in patients from Africa, we'll add on testing for schistosomiasis, filaria, and then often a blood smear for loa and urine microscopy looking for schisto. And so, one stool microscopy has fairly good sensitivity, and then one can increase as needed. So I wanted to shift gears now and really focus in on Chagas disease. And to hit home why we need to think about this diagnosis, I wanted to start with a description of a patient. So this was a 42-year-old female that I was seeing. She was from El Salvador. She was the mother of 2 children, healthy. She had some prediabetes, but otherwise was great. And so I was called from an outside hospital because she'd been admitted with a large frontoparietal stroke. And at that point, she had dense aphasia. She wasn't speaking, and she was hemiplegic. She wasn't moving half of her body. And the etiology for this was that she was found to have an aneurysm of the wall of her heart, so an outpouching of the ventricle. She had a thrombus there, and parts of the left ventricle were not moving. And ultimately, this was from her Chagas disease. And I'll tell you that this raised many issues for me because this was a patient that I actually had been trying to care for more than a year. And some of those societal factors that Dean Galea mentioned really came into play. This was a patient who had a difficult time getting in to see me because she worked at McDonald's. She wasn't given any time off from work. When coworkers had asked for time off, they were fired. And so she couldn't make her appointments with me. When we had tried to get her medication for her Chagas disease, they had asked for, the pharmaceutical company had asked for payment slips or sort of her evidence of her working, and she wasn't able to provide that. And so there were so many societal factors that played a role in this, and ultimately she ended up with a stroke. So if you're hearing about Chagas disease and you're thinking, well, maybe I learned about this at some point in my medical or nursing or whatever training, but you can't really remember that much about it, you're not alone. So there was a study done in 2010, and of more than 1,000 US clinicians, more than a half had not heard of Chagas disease or were not confident in their knowledge. But this is really a critical problem because from the patient side, there was a qualitative study done, and this is a quotation from a patient with Chagas disease who said, I thought I had a doctor, a clinic who could help me, but nobody knew what Chagas disease is. My doctor didn't know and sent me to a specialist, but nobody knew what to do with me. And after a year, I gave up. So our hope actually is to help spread the message and make people aware. So with funding from the Centers for Disease Control, we cooperative agreement, we're trying to help roll out screening programs sort of locally and nationally, and you can see our team there as part of INSECT. So what is Chagas disease? As a reminder, this is American trypanosomiasis caused by the parasite Trypanosoma cruzi. It's transmitted predominantly by triatamine or kissing bugs, which are found in sort of walls of and in thatched roofs in endemic countries. Critically, though, it is also transmitted through vertical transmission from mother to child. So even if somebody is not living in an endemic country anymore, there's still the potential for transmission. It is also transmitted through transfusion and organ transplantation, and more rarely through contaminated food and drugs, food and drinks. So there's been large outbreaks, for example, with sugarcane juice that's contaminated with these triatamines and their feces. So where is it endemic? It's endemic in Mexico, Central and South America, and in the Southern United States. I will note it's not in the island nations, so that's less of a concern for those patients. But we have a large number of immigrants in the United States that are likely infected with Chagas disease. To put this on as a comparator, that's more than twice the number of sort of new syphilis cases that are diagnosed each year, and yet we are not making a diagnosis of Chagas disease. What's the potential impact? Well, among those more than 300,000 Chagas disease cases, we estimate that up to 45,000 have cardiomyopathy, and we're going to talk about the details of that in a second. This has huge healthcare costs, and you can see a particular gap because only about 4 to 6% of immigrants with Chagas disease are aware of their diagnosis. And based on treatment records from the Centers for Disease Control, we know that Less than 1% of these individuals are getting treated. So that's a huge gap. Chagas disease comes in different phases. The acute infection, where one is sort of bitten by this reduvid bud, generally people will have a fever, they might have a chagoma or a Romagna sign at the site of initial infection. And then people will generally enter an indeterminate phase where they're asymptomatic. And about a third of people will go on to complications that are both cardiac and gastrointestinal. I'm going to focus in on those cardiac abnormalities because those are a particular concern. We talked about those potential for aneurysms and thromboembolic disease, the outpatchings of the wall, and the potential for stroke. But the heart rhythm and myocardial abnormalities are critical. The most classic EKG abnormality that you'll see is a right bundle branch block, and you can see there those typical bunny ears. So that accounts for more than 50% of the EKG abnormalities. But you can also see left anterior fascicular block. You can see tachyarrhythmias, bradyarrhythmias, and a variety of different arrhythmias. So just to highlight this, I had a patient who was a 59-year-old female from Colombia, and actually the infectious disease fellow was seeing her with me. And she was referred for positive Chagas serology. She recalled what was likely a Romagna sign back in Colombia. But she was in the office and that fellow said, you know, she's feeling pretty lightheaded and she's feeling faint. And so we did an EKG. She had a sinus bradycardia, first degree AV block with a prolonged PR interval. So we then sent her for an event monitor that day, and she had an 11-beat run of non-sustained VTAC, which is a really poor prognostic sign. And she had pauses of up to 6 seconds long without any heartbeat. So you can imagine why she's feeling that, the lightheadedness. So she got admitted then and got a permanent pacemaker placed. So Chagas disease is really important to think about because it's a significant risk factor for sudden cardiac death. So sudden cardiac death accounts for almost 2/3 of deaths in patients with chronic Chagas cardiomyopathy because of ventricular tachycardia, VFib, asystole, and heart block. Other causes of death are from heart failure and embolic events. So these are generally young, healthy patients who die suddenly. Heart failure this is the leading cause. Chagas disease is the leading cause of heart failure in Latin America. And patients that are infected, blood donor studies have shown that about 2% will progress to cardiomyopathy yearly. We check an echocardiogram in everyone because patients can be relatively asymptomatic, but you can detect early signs of heart failure that can be harbingers of sort of worse states later on. And these patients tend to do worse compared with patients with heart failure for other reasons. So when one's looked at Latin American immigrants with non-ischemic cardiomyopathy in Los Angeles, almost 20% had Chagas disease, and these patients are again at increased risk of death or transplant. The problem is that testing is not happening. So Elise Wielak is an infectious disease fellow working with us who did a study of more than 3,000 patients at the hospital from endemic countries with EKG and echo findings consistent with cardiomyopathy, and only about 1% had been tested. That's 1% of patients with findings consistent with cardiac Chagas disease. Of those, 8 tested positive. So there's clearly a gap in testing that's happening. Testing is quite easy. There's a blood test. One orders just a T-Cruzi antibody, but then confirmatory testing is required. We generally send that to CDC because you need to have 2 different antigens, 2 different tests to confirm CDC or to confirm Chagas disease. So I did want to highlight one particular program that has been really sort of changing the face of Chagas disease, and that is the Strong Hearts program that was developed by Julia Kohler and Jen Mangoler that you can see on the bottom, and that's at the East Boston Neighborhood Health Center, where they have started screening patients from endemic countries for Chagas disease. They've screened over 8,000 patients, and of those, about 1% have confirmed positive, and those patients are referred to David Hamer and myself for treatment at Boston Medical Center. And they've really shown that community-based screening is feasible. Why screen? Because you want to prevent vertical transmission from mother to child, prevent disease progression with treatment, and get those patients with cardiac involvement, get them appropriate monitoring and treatment. So in conclusion, I wanted to underscore the importance of thinking about parasitic infections in migrants, Don't ignore eosinophilia when you see it. Please consider the diagnosis of Chagas disease, the implications for cardiomyopathy, arrhythmia, aneurysm, and stroke. And I will just highlight there that the patient that I initially mentioned who had a stroke is actually doing well. Her aphasia has resolved. She's actually completely, essentially back to normal, thankfully, but I think she underscores for us the importance of thinking about this diagnosis. So I just wanted to acknowledge the team that's played a part in this, the collaborators at Strong Hearts and our funders at CDC. Thanks so much.
Thank you, Dr. Hochberg. And I'm going to just direct you, there's a question in the Q&A that is specific for you. But in the meantime, we will go on to our last speaker, Dr. Gloria Ruiz. So Dr. Ruiz is also a longtime colleague and friend of mine. So it's wonderful to be able to have her speaking to you all today. She's a trained medical professional and a healthcare manager and has had experience across a range of departments at BMC and many different public health initiatives, but specifically works in administration, personnel, grant management, and strategic planning. Her particular interest and research is in disenfranchised populations and healthcare disparities, and has worked most recently in those who are at high risk of acquiring or affected by HIV, STDs, hepatitis C, TB, and COVID, and then particularly where that intersects with addiction and homelessness. She's also served in medical missions in the US and internationally, and is going to be talking to us about what we have seen about in the immigrant population around COVID and COVID vaccinations. Thank you so much, Dr. Ruiz. It's delightful to have you here today.
I am so happy to be here with all of you, and I'm going to start sharing my screen so that you can see the presentation. Really, really happy to be here. And in the interest of time, I'm going to project like this so that I can make sure that I hit the important notes and leave some questions as well, time for questions as well. My only disclosure is that my salary is partially supported by a grant from the Gilead Focus Foundation. And then the goal for today is to talk through some myths very quickly and also understand the reluctance of COVID-19 vaccine hesitancy among vulnerable patients, and also discuss strategies to encourage vaccination. So first, a short note on data. So our state's positivity rate has been declining after the holiday surge, as you see here, which is a very, very positive trend. And also that reflects with wastewater data and other metrics that we follow closely. What's giving us pause right now is that we are actually seeing that despite this initial dip, in the last couple of days, and couple of weeks, we've noticed that the trend stopped from going down and is now kind of like plateauing. So we're monitoring that closely. And again, this highlights the importance of vaccine uptake in our community. So let's talk through some of the things that our patients have identified as barriers. And a lot of that is that we are at the crossroads of a crisis, not only with the COVID pandemic, but also misinformation and health equity. And they're all colliding crises. And this has only been highlighted as part of the vaccine rollout. So some of the questions we've been hearing in virtual and in-person rounds and one-on-one encounters are, does the vaccine keep me from getting COVID? Do they work? Do they work in people in Black and Brown communities and immigrants? Can pregnant people take them or breastfeeding people? And this is also largely driven by the history behind the encounters and the experiences that our disenfranchised and vulnerable patients have had with the medical system. So these are not unusual questions when you take them in that big context. And we'll talk about that in a few slides. So some of the common myths we've heard, it was that developed really quickly. It contains a virus, microchips. It will change your DNA, and it's amoral because it was made using fetal tissue. And this is an opportunity to kind of, again, reiterate that the vaccine does not contain any fetal tissue and that it is not believed that to cause infertility or miscarriage. And we know that as well because of one of the issues in our history is that Black and Brown women have been disproportionately impacted by issues regarding disparities in reproductive health, because that is one of the first things to be attacked when a population is deemed a minority and like somehow like different. So the COVID vaccine, yes, it was developed in record time, but it was put to the same rigorous scrutiny to ensure its safety and efficacy. This is not a new technology, especially for the mRNA vaccines, certainly not for the virus vector vaccines. And, you know, it was not something that was new, but yet it was plagued by a lot of uncertainty just because of how rapidly it was approved. And the name Operation Warp Speed certainly did not help convey that sense of having a lot of time to kind of think this through, because warp speed conveys almost like it was done in a hurry. And that's feedback that we've received from our patients as well. So how do they size up? They're very effective, and they're incredibly effective in preventing hospitalizations and death. And they perform very similarly, including Johnson & Johnson, which is now under pause as we examine the 1 in a million chance of blood clotting. And we are looking at that very closely. And I think that is an opportunity to reiterate for our patients, colleagues, community members that we are being very, very thorough in examining that important side effect to make sure that we are confident in what we're putting out there for the community. And that is the right thing to do, to just think it through very closely. But in the end, they perform rather similarly. And the way that they work is that they have an mRNA carrier, those Pfizer and Moderna, the ones that we're using as of today. And that is coding to make a spike protein that then will trigger an immune response. A note on variants is that we are monitoring closely and understanding every day a little bit better how these 3 variants have an impact any kind of vaccine efficacy, and also disease, severe hospitalization, etc. So that is something that we're learning more and more every day on how they perform. So that is also something important to note as well. So in terms of COVID-19 impact on communities of color, this is of no news to anybody, but the issues regarding health equity have been even highlighted even more in the COVID-19 pandemic, because it has worsened the already existing disparities that were mentioned by our previous speakers regarding infection rates, regarding hospitalizations and death. And they manifested across the board during the COVID-19 crisis in 2020, and they're still manifesting today. And we saw increased numbers of hospitalizations and death in Black and Brown communities. And here's a depiction of how this looked like from the CDC compared to white individuals. And in Massachusetts, we had the exact same experience. BMC became the COVID hospital in Boston because of who we are and who we serve. And that largely had to do with the fact that a lot of our patient population is disproportionately impacted by social determinants of health. They are essential workers. They have barriers for to transport to appointments, as Dr. Hochberg's patient case illustrated extremely well. And that is the story of our patients. And again, that is how COVID-19 disparities manifested as well during the crisis of last year. And that is something that we're still looking at very closely as we tweak the COVID-19 vaccine rollout to meet the needs of our patient populations and meet them where they are at. So we have to acknowledge that the medical field has a really sad history of racist abuse and mistreatment of vulnerable patients. Everybody knows Tuskegee and Henrietta Lacks and the impact that this had in our Black community. And that is something that has again been manifested in the COVID response. The feeling that somehow these vaccines are some sort of conspiracy theory, that they are made for other people that don't look like them. And again, this is kind of like an important, but it's also important to take into consideration that this is not a thing of the past. And this actually history of racist abuse, mistreatment, neglect but our medical community is also taking place today and has been the experience of a lot of our Black and Brown patients. So it's not something, a thing of the past, and that is why it's important to continue to address health inequities across communities of color. So here's an example from something that hits close to home. I am a woman from Puerto Rico, and in Puerto Rico, not so long ago, we were the site for the Enovid birth control pill trials. And we did not know that we were part of a trial. So that is, again, something that has stuck to us in our Latin American communities, Puerto Rican women for sure. This is something that kind of like fuels those misconceptions that I mentioned earlier around the impact of new initiatives, new medications, new vaccines regarding the impact on reproductive health. And so what this is here, this is a picture of a slum in Puerto Rico, del barrio El Fanguito, which means little mud, and you can see why. And those were the recruitment sites, that this was one of the recruitment sites for those birth control trials. The problem was that the women did not know that they were being experimented on. And those are the kind of historical things that we need to remember. Also in the 60s, a third of the female population in Puerto Rico, for instance, and they were not educated, they were sterilized and they were not really educated on the permanency of tubal ligation. One of those women was my grandmother, who was sterilized at the age of 17 while my grandfather was deployed, serving in the Marines. And remember, in those days, those were the days where men needed to consent for women to get sterilized, and she was sterilized at age 17 after having my uncle. So, okay, we know all this. Here's a vaccine rollout plan, and we are by design tackling the vulnerable, right? We are looking at people that are older, we are taking at people who are sicker, and we're starting by them, so that is going to go great. Until it didn't. And what happened was that COVID-19 added a new healthcare disparity, broadband access to access to internet and digital literacy. It's almost as if we didn't learn the scope of the impact of internet and access and literacy, as if we didn't learn it with the school rollout of remote learning. So then we started to see things that happen. The application is crashing, very long wait times. And this is if you were lucky enough to have access to some sort of internet, which we know our immigrant and refugee patients may struggle with. So then, what are the strategies to encourage vaccination in our community? Well, we have to meet patients where they're at. Here are 3 examples of something that, a few initiatives that we've done at BMC to help with this. This is a canopy that we set up and we still have to this day at Project Trust, which is a center for a drop-in center for persons who inject drugs and live on the streets. And this is us doing education and harm reduction material distribution. And that goes harm reduction for substance use, syringes, and injection supplies, etc. But also we dovetailed our expertise in public health, communicable disease prevention, and we rolled in COVID as well. So we were also distributing masks, hand sanitizers, and cut from the picture is a hand washing station, a portable hand washing station that we hooked up. Here is the geriatrics vaccine program for homebound individuals. And then here was the East Newton COVID recuperation unit that we set up for our homeless patients to recover. So it's always a matter of thinking outside the box and meeting the patients where they're at. And in that spirit, we set up community clinics in different sites across the state, across the city of Boston rather, where there is a larger incidence of communities of color. We took the incident map and we were very deliberate in positioning over it in the darker areas where there were new cases and new deaths from COVID and placing the sites there. And they're very, very cool in the makeup because they're very different. So we had a YMCA one, we have the Great Roslindale, the Corinth Street. This is Morning Star, which is a church, a Baptist church, and that is on top of the in-home vaccinations and other things that we are working on, which I'll show you in a second. So why is this important? because we know that not a lot of our patients are capable of booking an online appointment and staying up until midnight when some of the appointment slots open up. We need to have a multifaceted approach. The phones, the good old phones came in and have been very effective. So we've doubled down our efforts in the call center. We're doing street outreach. We're engaging with these community partners. And we're doing everything we can to go to the patients to take away the barriers that prevent them from coming into a doctor or to one of the mass vaccination sites to get vaccinated because they're really far away. As a result, we're tackling a completely different demographic than the Massachusetts vaccination sites. And that is great, not because we're better or they're better, just because we're targeting a different population and we have a different purpose. The purpose of the vaccination sites, such as Gillette Stadium and Fenway, is just sheer volume. Our job has been, and our mandate has been, to focus on the patients that just can't get there. And what this shows is actually that we are being successful at having larger vaccination rates in persons of color and also persons with high social vulnerability indexes as defined by the CDC. So what you see here is a proportion of people that are Black and brown, Black and Latinx in particular, these are the two big pieces of this pie. And then this is the number of social vulnerability index indicators that our patients have. And we see that there's a larger variability here because we are tackling people with a lot of housing, transportation, medication access issues. Be deliberate about including people and peers who are willing and able to speak in different languages. Here we have a reverend of our church speaking. We have a multi-language approach. We connect with community advisors. We have been sharing testimonies. This is me, I recorded it in English and Spanish. And we are also encouraging people to just get out in the community on foot, as you see here, and just make sure that we are doing what we can to meet them. Any kind of outreach, text, letter works. And then what this is basically what our community sites are. And again, they're very varied, and we are extremely excited of how they're working, and we're looking forward to expanding them some more to reach the patients and meet them where they are at. So with that, that is the pause of my presentation, and I am going to check the chat, and if there's anything else, that's it for me.
Thank you so much, Dr. Ruiz. We really appreciate your sharing all of the hard work that's been done to particularly try and mitigate the disparities that we've seen in the COVID migrant population in Boston. So I personally appreciate your work in that front. So we are at time. So we've been trying to answer the questions as they've been coming in through the Q&A and chat, but feel free to throw any last questions in if you have them. But overall, just really want to express our appreciation to our speakers today for all of their work putting together this information to share out. But also for all of us who are here caring about immigrant rights and immigrant health, just knowing that there's such champions who are fighting in the different areas of infectious disease, COVID vaccination, health screening, and access to social determinants of health support is necessary and critical. So thank you all for your work and for sharing it today. And we'll close there, but if there's any other questions, please feel free to put them on the chat and the question and answer.